welcome back, everyone, to the Canadian Concussion Center's webinar series. And thank you so much for joining us. We've switched things up a little bit. We're on a different night and at a different time. So it's nice to see people joining. This is actually our last webinar of 2025. And if you haven't been with us before, you should know that we run the webinars. They recur every other Tuesday evening, and we have different topics where we've got expert speakers that talk on a wide range of concussion-related symptoms. And then the second half is designed for you to get your questions answered. So if you have a question tonight for our speaker, if you just sort of move your cursor around, you'll see at the bottom of your screen there's a Q&A. So if you have a question, please just enter it into the Q&A. There's also a chat. If you happen to have any technical questions, please enter them there, and Christian will can answer you. And I'm just seeing a few people entering their names and some greetings from Pennsylvania and Delaware. So that's awesome. Welcome. Uh, okay, so just always before we go any further, just want to acknowledge the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands that we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. And as we always do, we're just going to run a quick poll to get a sense of who's in the audience. And it's amazing. I'm seeing people on here from Mexico and Australia, all over the place. So welcome. But it's always helpful for us to get a sense of who is attending in terms of gearing our talk. So I'll just give you a second there. Okay, great. So I am really pleased to welcome back Dr. Neal Parekh, who's going to be talking about traumatic brain injury and sleep. Sleep is a huge issue for many people, and so I'm really looking forward to hearing more. After graduating from medical school at the University of Toronto, Dr. Parekh completed his neurology residency at the University of Ottawa. He then returned to the University of Toronto to pursue a fellowship in sleep medicine. He holds certification in medical legal expertise through the Canadian Society of Medical Evaluators, as well as certification as a somnologist expert in sleep medicine through the European Sleep Research Society. Dr. Parekh has over 15 years of clinical experience. He was previously the chief of neurology at the Scarborough Hospital and Peterborough Regional Health Centre. He's currently the medical director of the neurology program at Altum Health at the University Health Network, and he holds an adjunct clinical appointment with the University of Toronto. So with that, I am going to turn it over to Dr. Parekh.
Thank you so much, Leslie, and thank you to the Canadian Concussion Clinic for inviting me, and thank you to everyone on this call for pivoting and joining us on a Wednesday. I'll be discussing common sleep issues in traumatic brain injury. There are several differences in terms of the sleep problems that we see in concussion as opposed to in those individuals with moderate or severe traumatic brain injuries. We'll be focusing today on the sleep issues that are seen in or result of concussion specifically, just to keep us under the 30-minute mark. So I don't have any disclosures as it pertains to my role as a neurologist. I have sat on an advisory board for a medication used for insomnia. This class of medication will be mentioned in this talk, but the specific brand will not. So we're going to start by just reviewing some very basic sleep physiology, and really the purpose of that is to make sure we have a pretty broad audience. So I just want to make sure that people are familiar with the terms I'll be using as we march along through the presentation. We'll talk about how to identify some common sleep disorders in the TBI population, and then discuss at least initial approach to the treatment of these common issues. So very quickly, sleep is defined electrographically. There's several different stages of sleep. The ones that I want to highlight are REM sleep, which is the state of sleep where we dream. It's also a state of sleep where our brainstem sends signals to the rest of our body to paralyze our muscles. And that'll become particularly relevant later in the talk. Delta sleep or slow wave sleep. This is the type of sleep that we feel is thought to be important in terms of its ability to restore. Through the night as we sleep, we march through cycles, and as the night goes on, we progressively spend more and more time in REM sleep and less time in what we now call stage three or N3 sleep. And again, there's a reason I bring this up, and it'll become more apparent shortly. So we know that concussion or mild traumatic brain injuries can affect sleep architecture. A head injury can result in more time being awake in the middle of the night. It can reduce our sleep efficiency. It can prolong how long it takes for us to fall asleep. So certainly physiologically, there's consequences to having a brain injury. Sleep is regulated by two processes. The first is homeostasis or sleep debt. So essentially, the longer we're awake for, the stronger the drive to sleep. This is sort of the reason why a nap in the late afternoon or evening can make it hard to fall asleep at night. The other process that regulates or controls our sleep is our internal clock or circadian rhythm, which is a process that can be influenced by a variety of things, most strongly light. We believe that using electronics in bed, for example, or the light from electronics in bed can influence our circadian rhythm, also making it hard to fall asleep. There's lots of theories as to why we sleep, but essentially, I think what's agreed upon is that sleep is important for probably a variety of reasons, including the fact that it can impact other domains that are commonly derailed following a head injury. So there's been studies showing that in patients who are sleep deprived, our pain thresholds change, meaning things that are uncomfortable or painful feel more painful when we are sleep deprived. We know that sleep deprivation can affect cognition. Sleep disorders are often a contributing factor in fatigue, and poor sleep or a lack of sleep can also result in mood issues. Some of these issues are bidirectional, of course. So if we're anxious or depressed, or if we're in pain, that can also impact our ability to sleep. So sleep disturbances are common post TBI. There's a variety of sort of numbers that have been published, but what seems to be agreed upon is that at least 50% of individuals following traumatic brain injury have some form of sleep disturbance. There's been studies looking at the prevalence of the common sleep disorders after a head injury, and the common theme is that most of these are more common following a TBI. Another study looked also at nightmares, suggesting that they're about 3 times more common following a head injury. So just a little bit more nomenclature. So insomnia, simply put, is difficulty sleeping when one wants to be asleep. Hypersomnia is difficulty staying awake when one wants to be awake. And a parasomnia is an abnormal or unwanted behavior occurring out of sleep. So the International Classification of Sleep Disorder, they categorize common sleep disorders um, into sections and we're going to march through those sections and talk about which conditions are most commonly seen post MTBI or post concussion. So insomnia, probably the most commonly seen following a head injury. We can sometimes see sleep initiation insomnia, meaning difficulty falling asleep when we first get to bed. Also commonly seen is sleep maintenance insomnia, and that's difficulty staying asleep. Insomnia seems to be much more common in individuals with a mild traumatic brain injury, where we often more commonly see hypersomnia or excessive daytime sleepiness following a moderate or severe traumatic brain injury. And almost half of patients, based on one questionnaire, um, seem to have persisting insomnia beyond 6 months. So again, chronic insomnia disorder being very common post-concussion. And we define chronic insomnia disorder as insomnia that has daytime consequences and that the insomnia is persistent for at least 3 months and not due to other medical or psychological conditions. Also frequently seen are sleep breathing issues. Uh, Much more common is obstructive sleep apnea, which is a condition where our upper airway repeatedly narrows or collapses while we're sleeping. And there's a few different theories as to why obstructive sleep apnea might be more common post-concussion. So, uh, one theory set forth is that having sleep apnea predisposes us to having an injury to begin with. So that could be, falling asleep while while performing certain activities, or it could be inattention due to sleepiness. Another theory as to why sleep apnea might be more common in the post-concussion population is that maybe sleep apnea actually is a barrier to recovery. Or maybe sleep apnea gets worse indirectly. So that could be from weight gain following an injury, which often happens due to inactivity or some of the medications we might use post-concussion. Um, and then there is central sleep apnea. So both of these conditions are characterized by um, cessation of breathing through the night. Obstructive sleep apnea is essentially a blockage or obstruction due to the upper airway collapsing, whereas central sleep apnea is essentially the brain not initiating or triggering the breath. So, as mentioned earlier, obstructive sleep apnea can be seen or can worsen due to weight gain. Certain sedatives or muscle relaxants can also worsen sleep apnea. If craniofacial trauma is severe enough, such that it distorts the anatomy, that can also result in obstructive sleep apnea. Central sleep apnea, which again is when the brain fails to trigger a breath, is most commonly seen in the post-head injury population when opioid medications are used for pain relief. The next category is a little bit less relevant to the post-concussion population, so that is the central disorders of hypersomnolence. But what is important to note is that some of the medications that we use can result in daytime sleepiness. So that could be sedating antidepressants, sleeping pills, painkillers. Sometimes people will use alcohol to cope. And so all these substances can cause excessive sleepiness. There are conditions that are more commonly seen in moderate to severe traumatic brain injury, but we won't spend too much time on that today. So circadian rhythm, sleep-wake disorders, and so again, as I mentioned earlier on a previous slide, one of the systems that help regulate our sleep is our internal clock. And interestingly, one Canadian study found that about a quarter of people with MTBI who have chronic insomnia actually were determined to have a circadian rhythm sleep-wake disorder, predominantly delayed sleep-wake phase disorder, where our internal clock is shifted such that our brain kind of thinks it's time to go to sleep much later in the night, and similarly, that it's time to wake up much later in the day. Another common issue is that some individuals who are, doing quite well, doing shift work following a concussion, their ability to cope or adapt with that kind of schedule can become an issue where staying awake at work or sleeping during the day can become difficult and therefore create issues with coping while at work and coping with a already sort of rigorous work schedule. So parasomnias, these are again unwanted or abnormal behaviors in sleep, and there are two that are commonly seen post-concussion. The first is REM sleep behavior disorder, and that is a condition where our brain fails to adequately paralyze our muscles during REM sleep, resulting in us acting out our dreams, and that can lead to physical injuries to a patient and to their bed partner. And the second sort of common parasomnia is nightmare disorder. So REM sleep behavior disorder, again, it's dream enacting behavior. We worry about it leading to potential injuries. It can be seen in association with post-traumatic stress disorder, but far and away the most sort of common cause in the context of concussion is the use of antidepressants. Nightmare disorder, which is essentially just recurrent or frequent nightmares that are causing some kind of distress or impairment. Also, commonly a result of medications that we might use for headaches, for example, beta blockers, or for anxiety or depression. And nightmares can also, rather than being its own independent disorder, be associated with post-traumatic stress disorder and other psychological conditions. Moving along to the sleep-related movement disorders, restless leg syndrome, which is a condition where individuals have an urge to move or shake their legs. This is typically seen in the evening or at night while at rest. The other sort of related condition is periodic limb movement disorder, which is characterized by stereotyped periodic movements of usually the legs, which can also disrupt an individual's sleep and their bed partner's sleep. And sleep-related bruxism, which is a clenching or grinding of the teeth, also commonly seen post-concussion. So restless leg syndrome, we talked about briefly. Um, just to be aware that antipsychotic medications or antidepressants that are commonly used post-concussion can cause restless leg syndrome. Patients are often, um, it's often not sort of self-reported and only endorsed when specifically questioned. So it's important to ask about that in individuals who are having trouble falling asleep. Periodic limb movement disorder, uh, again, can be caused by the same medications that can cause restless leg syndrome, so antidepressants and antipsychotics. Also, antihistamines and stimulants can also contribute. And this tends to cause a sleep maintenance issue, um, as these limb movements can be associated with awakenings or arousals, and when dramatic enough, can also disrupt a bed partner's sleep. Sleep-related bruxism is a repeated teeth grinding or clenching that can occur during sleep. Sometimes it's noticed by a bed partner because of the noise. Sometimes dentists identify it based on patterns of wearing of the teeth. It can lead to injuries of the soft tissues of the mouth, biting of the cheek or biting of the tongue. It can also cause jaw pain or headache, particularly a morning headache. And lots of risk factors have been identified, uh, including certain medications, anxiety, sleep apnea. So, when presented with a sleep disturbance or a sleep problem, the first step is, of course, to take a history, and this includes um, probably most importantly a sleep routine. Much can be learned uh, about a person's sleep just by understanding what their routine or sleep patterns are like. A physical exam is part of the assessment, and then we will often use a variety of different tests or investigations to gather more information. And we'll just briefly walk through some of these tests and just what they mean or what they entail. So again, in terms of the sleep history, important to ask about a sleep routine, which includes the time somebody gets into bed, what they're doing in bed before they attempt to go to sleep, the time that they try to go to sleep, how long it takes to fall asleep, pardon me, the number of awakenings in the night, what time they finally wake up, what time they get out of bed, and whether they nap, and if so, what time and how long. Important to go through a review of systems. Questions around snoring, witnessed apneas, morning headaches might point to obstructive sleep apnea. Asking about grinding or clenching, particularly important when patients endorse headaches in the morning. Um, Asking about excessive daytime sleepiness because this can have consequences, consequences when behind the wheel, consequences when at work. Um, for individuals who have trouble falling asleep or staying asleep, asking about restless leg symptoms or leg jerking or twitching during sleep. Important to ask about nightmares because this can cause a great deal of distress. And of course, asking about any violent behaviors that could result in potential injury. So in terms of investigations that are used, just very briefly, so a sleep diary is commonly used, and that's essentially typically a 14-day log. And it's just a record of an individual's uh, sleep habits over a 24-hour period, but looking more broadly over a 14-day stretch. Actigraphy, or an accelerometer, which is essentially an accelerometer, it's a device worn that detects movement, which helps us estimate when an individual might be asleep or awake, and therefore estimate total sleep time. The term polysomnography, uh, sometimes referred to as a level one sleep study. This is a sleep test that's performed in a laboratory setting that's monitored by a sleep technologist, and a host of conditions can be identified or diagnosed through such a study because of the number of parameters that are measured during that study. A level three sleep study, on the other hand, really is a test to look for sleep apnea. It's a test that is performed in an individual or patient's home. Um, in Ontario, this type of study is not, I realize there's people from all over the place, but for those of us who are Ontario based, this type of study, a level three sleep study, is not paid for by our public health system, but that will likely change in the near future. A multiple sleep latency test is a test that allows us to somewhat objectively um, measure sleepiness and is often used to diagnose conditions such as narcolepsy. Um, this really is measuring the ability to fall asleep when one wants to fall asleep because it is essentially multiple attempts at taking a nap. and what's measured is the average time it takes to fall asleep for each nap. This is a little different than a maintenance of wakefulness test, which is a test where an individual is asked to sit in a chair and stay awake for a period of time. So this is measuring one's ability to stay awake when they want to be awake, and it's often used to confirm fitness to drive when excessive daytime sleepiness is a concern. So when posed with um, a symptom of insomnia, so that means uh, in a an inability to fall asleep or stay asleep, it's important to identify and treat any primary sleep disorders. So conditions such as obstructive sleep apnea, periodic limb movement disorder, nightmare disorder often um, present as difficulty uh, staying asleep, whereas conditions like restless leg syndrome or circadian rhythm sleep-wake disorder often present as difficulty initiating sleep, though it's not exactly that binary, and certainly these conditions um, uh, don't always kind of respect that rule. When there is insomnia, it's important to address any psychiatric factors like depression or anxiety. It's also important to inquire about and address any medical factors, so pain that might be making it difficult to fall asleep or stay asleep, nocturia, so needing to pee in the night. Um, Reflux can be worse at night because we're laying flat, and so gravity is eliminated. Also important to ask about any shortness of breath when laying flat. And it's also important to interrogate what medications people are using, because many medications can make it uh, difficult to fall asleep at night. And that's not just caffeine, of course, but stimulants, activating antidepressants, steroids. There's a host of medications that should be timed um, accordingly if they are wake promoting or stimulating. So again, when somebody has insomnia, the symptom, it's important to review sleep hygiene. And I imagine that most of the people here on this call are familiar with sleep hygiene. So, but very briefly, that involves keeping a consistent sleep routine, avoiding caffeine and other substances close to bedtime, avoiding electronics in bed, eliminate napping when possible, ensuring the room is dark, quiet, cool, and safe. So again, there's insomnia, the symptom, that's just difficulty sleeping when one wants to sleep. Chronic insomnia disorder is the condition where there's the insomnia symptom without an underlying medical or psychiatric or sleep disorder as the cause of that symptom. So, uh, chronic insomnia disorder, the first line treatment is cognitive behavioral therapy for insomnia. And the issue with cognitive behavioral therapy for insomnia is that it is often difficult to access for a variety of issues. It's hard to find trained professionals. There's also a time commitment, but there's lots of studies showing that in the TBI population, um, that CBTI is effective and feasible. And there's many different components of CBTI. So sleep hygiene certainly is a component, and so that's addressing any or eliminating any unhelpful sleep or lifestyle habits. Stimulus control therapy is essentially a strategy to limit the time in bed while awake. So we're trying to strengthen the bed sleep association. Sleep restriction therapy is limiting the time in bed um, to drive or increase efficiency of sleep, and then to later extend the time in time in bed to ensure an adequate total sleep time. Relaxation is techniques are part of CBTI, as is um, uh, cognitive therapeutics and education. Although melatonin is not recommended for the treatment of chronic insomnia disorder, as it pertains to chronic insomnia disorder in the context of concussion, it is a reasonable and safe option. So there have been now a couple of studies demonstrating that after a traumatic brain injury, that some individuals actually produce less melatonin. So I should have started by mentioning melatonin is something that our bodies make in order to regulate our circadian rhythm. It is produced in our heads from the pineal gland, so it is um, certainly mechanistically feasible that or believable that a head injury could result in less production of melatonin, and that has been demonstrated in a couple of studies. And several studies, including some randomized controlled trials, have demonstrated that melatonin can be effective at improving sleep. So, what do we know? We know that melatonin is reasonably safe. Um, it is relatively affordable. What we don't know is what dose to use. Um, Nor do we necessarily know for sure what time to take it. But if we extrapolate from the use of melatonin in circadian rhythm sleep-wake disorders, it's probably most appropriate to use a bit of a lower dose um, and to take it approximately 2 hours before bedtime. If CBTI fails or is ineffective, and if melatonin is also similarly unsuccessful, then there are medications that we can use for sleep. Many of the medications that exist are probably appropriately used when treating a comorbidity. So I'll just give an example. Tricyclic antidepressants, such as amitriptyline or nortriptyline, are often used for headache. So in an individual who has headaches, it would be reasonable to use such a medication at bedtime, harnessing the sedating quality or sedating side effect of the medication to promote sleep. And the same rationale can be used for some sedating antidepressants. Um, but in the absence of treating a comorbidity, um, probably best to avoid what are referred to as the Z drugs, which can have some side effects that are not too dissimilar from symptoms of concussion. There is a newer class of medications, the dual orexin receptor antagonists. These are felt to be safe medications and have been demonstrated to not impair cognition or impair fitness to drive or impair balance. So probably a safe option in the concussion population. If obstructive sleep apnea is identified, um, it's important to remove any offending agents. Uh, Weight loss might be appropriate. Sometimes just avoiding sleeping on the back is sufficient. There are oral appliances that can be used to advance the jaw, thereby opening the airway. CPAP is commonly used and sometimes surgery. If central sleep apnea is present, there's often an offending agent that needs to be removed, but sometimes CPAP can be used. I'm realizing that we're going a little bit over time, so I'm going to maybe, in the interest of time, skip this slide. REM sleep behavior disorder, I'll just spend a second on because it is a safety concern. So, very important to reduce or eliminate any offending agent, i.e., an antidepressant. We sometimes use melatonin in this context as well to reduce the nighttime behaviors, and sometimes a benzodiazepine, most commonly clonazepam, is used. For nightmare disorder, um, again, addressing any issues that might be contributing to the nightmares. Imagery rehearsal therapy or rescripting is a type of treatment that some psychotherapists or psychologists are well versed in, and the idea is just teaching patients to kind of retell that story. So most helpful when the nightmares have a recurring sort of theme or storyline. And sometimes we'll use prazosin, which is an alpha receptor blocker, at night to reduce nightmares. Again, in the interest of time, I think we're going to skip over this slide. I apologize, but I think all these slides are going to be made available to everyone who's attending tonight. So very quickly, sleep disturbances and sleep disorders are common in the TBI population. Insomnia is very common and can be persistent. And it's important to recognize these sleep disorders because they are largely treatable. So thanks for your attention, and I think we still have 25 minutes for questions.
Great. Thanks so much, Dr. Parekh. That was excellent. Yeah, we've got lots of time. We have a number of questions. Sandy is asking, tell me your thoughts on using cannabis oil for sleep.
Yeah. So there have not been any sort of well done randomized trials looking at the role of cannabis. There have been several studies, and I think even one sort of meta-analysis looking at the use of cannabis. And honestly, the results are so uh, mixed that I don't think sleep physicians yet are um, really giving much of an opinion about its use for sleep specifically. That might change over time as we learn more and more about cannabis. I suppose the sort of the important thing to think about, though, is the other potential consequences of cannabis use. So, like any substance or medication that we're using for sleep, we need to kind of think of what kind of impact it can have in other domains and whether the risk to other things like cognition or mood, whether that might
Hmm.
outweigh the benefit it could have on sleep. But certainly the jury is still out on whether um, cannabis has um, a healthy impact on sleep and if so, exactly how it achieves that.
Okay, great. Thank you. Our next one is I've had insomnia and taken medication for 20 years since having a hysterectomy, and now have had a recent concussion. Even with medication, I can't sleep. Any ideas that might help?
Yeah. So, and again, I can't dispense specific medical advice, but just in I guess general terms, you're describing insomnia, the symptom. So, somebody should take a look at your medications, make sure that you're not taking a medication that may be making it difficult to sleep. We often use um, for example, antidepressants, but some antidepressants are stimulating. So making sure you're not taking something like that close to bedtime as opposed to in the morning. Um, Somebody should kind of review what's happening with you medically. Is there, pain or restless legs or something that's making it difficult to fall asleep? Again, also addressing your mental health adequately, making sure anxiety or depression aren't contributing. If you feel all these things have been addressed, and you're still having trouble sleeping, well, then we call this chronic insomnia disorder. So, meaning insomnia, the symptom lasting more than 3 months in the absence of a psychological condition, medical condition, substance that's causing that issue. And in that case, cognitive behavioral therapy for insomnia is the first line treatment. I recognize that it is not free generally, and so it can be difficult to access, and particularly depends on where you live and what resources are in your community. But that is the first line treatment by far for chronic insomnia disorder. So that might be something worthwhile
Hmm.
pursuing. Again, melatonin, um, some pretty decent evidence for its use post-concussion for insomnia. for chronic insomnia disorder in the context of concussion, that would be reasonable as well. Um, I don't know. I don't know your age, and I don't know if that hysterectomy also included an oophorectomy, but certainly postmenopausal, either surgical postmenopause or postmenopausal, sort of naturally, sleep apnea becomes much much more prevalent in women postmenopausally, and so if your trouble sleeping is trouble uh, staying asleep, certainly, maybe screening for sleep apnea might be appropriate. But again, without having all the details, I hesitate to
Hmm.
give specific advice.
Yeah. Okay, that's great. Thank you. This is another one that's a bit tough too. I have a doctor suggesting I should take prescribed sleep meds every night. There's a caution with the medication, which makes me think I need a second opinion. What are your thoughts?
Yeah, so I mean, if we okay, so I guess we can just talk about like things that are generally prescribed or recommended for sleep. And so, um, in terms of, let's say, over the counter or medications or supplements, melatonin again is the best uh, looked at. So again, in the context of concussion, um, probably reasonable to try. I think it's relatively safe. I mean, we all feel it is relatively safe, and so I doubt that's what's being recommended or prescribed, but melatonin would be reasonable to use. There are some antidepressants that are um, often used at night to help promote sleep, which are appropriate if depression or anxiety are uh, a significant um, a significant issue. Um, in the absence of depression or anxiety or any mood issues, then those medications should generally be avoided uh, for the sole, like if being used solely to help with sleep. The Z drugs are probably what's being prescribed, and again, you don't need to share that information. But what I mean by Z drugs is there's a few drugs that literally start with the letter Z. Um, Probably zolpiclone, otherwise known as Imavane, is the most common, but there are other zolpidem and these Z drugs. They essentially work on the same receptors that benzodiazepines or alcohol um, work on, and so some of the side effects or consequences are similar. So we worry about with these Z drugs dependency. We worry about the impact it could have on cognition, potentially on mood. So that I imagine is what um, is being prescribed and rightly cautioned about. So I think most family physicians who prescribe these Z drugs will give like a certain number of these pills per month, eight, and you can use, the eight whenever you need to. So agreed. If it is a Z drug, it should be used with caution. Um, But there is, like, as I mentioned earlier in this talk, that there is a sort of a newer class of medications, really a medication. I mean, they're sophisticated medications in the sense that they're actually working on, you know, the the neurobiological processes that create or promote sleep. So they're truly like a sleep medication rather than a medication that is causing a side effect of sleepiness. And these medications, these DORAs, um, are um, felt to be much safer than the Z drugs and are certainly higher and certainly for one of the medications that exist, they have done studies looking at driving the next morning, cognition, balance, and for these, and the results of the studies suggesting that, these medications are safe. So that might be an alternative, recognizing that the DORAs, dual orexin receptor antagonists, um, are expensive, much more expensive than the Z drugs. So sometimes that can be a barrier as well. But again, if it's a Z drug that's being prescribed, agree about using it with caution. And again, particularly because a lot of the side effects are the very things that individuals who've had a concussion struggle with.
Great, thank you. Does light from watching television in the bedroom affect the circadian clock in the same way as light from devices such as your phone or laptop?
Yeah, and so it doesn't take much light to um, uh, to uh, to impact or influence our circadian rhythm. I mean, fundamentally though, there's so many things that help us sleep and also so many barriers to sleep that it can be hard to know whether, some light influencing our circadian rhythm is actually going to cause a problem or not. Um, and so, but to answer your question, yes, even light from a TV has that potential. Again, without knowing distance and the size of the TV and how much light is
Mm,
being emitted, but it certainly doesn't take much. And so, it can never hurt to trial an alternative to a TV at night, right? Like, I think they still make paper books. You could purchase a book and try reading or something else and see if it makes a difference.
hmm.
Some people though
Yeah,
are just,
for sure.
great sleepers and can tolerate a lot more. And I have friends who can have a coffee at bedtime, and you would think, oh my gosh, but they sleep fine. And then other people, if they have caffeine mid-afternoon, they can't sleep. And so, everyone's a little bit different, but it can't hurt to. I would believe that the TV could cause an issue, and so it would be worthwhile maybe trialing without and see if you notice a difference.
Hmm. For sure. Thank you. Is there any correlation between insomnia um, and between insomnia elevating blood pressure or the reverse? Yeah, I guess if you're dealing with chronic insomnia, is there a tendency for blood pressure to go up after a traumatic brain injury?
Oh, that's a great question. So, there is okay. So this is like uh, a big question. So,
Yeah.
okay. So, firstly, um, there are um, conditions that can cause insomnia that can also elevate blood pressure. And I think that's what confounds probably a lot of things. But for example, we talked about, like, if we just talk about the general population, maybe outside of, let's say, concussion, if we talk about the general population, obstructive sleep apnea is quite common. And obstructive
Hmm.
sleep apnea has been shown in many studies to be associated with high blood pressure. And in fact, there's some studies demonstrating that when we treat sleep apnea, the blood pressure um, lowers or comes down. Similarly, periodic limb movement disorder, there's some studies demonstrating that when individuals have these leg kicks, they can actually elevate blood pressure. So, I mean, I guess the first thing I would, and some, um, uh, you know, things that, again, things that can um, impact um, sleep. Also, like anxiety is an example. Certainly, I've seen individuals whose blood pressure are higher while they're anxious or higher because they're in pain and these very things, right? So pain, which can elevate blood pressure, and anxiety, which can elevate blood pressure, can also cause insomnia. And so I think it's a bit of a hard question because so many of the things that make it difficult for us to sleep can cause high blood pressure on their own. But yes, there are lots of studies that show that insomnia or sleep deprivation generally are associated with cardiovascular risks. So whether insomnia alone can cause high blood pressure or whether both the insomnia and the blood pressure are a consequence of something else is it's a bit unclear to me.
Hmm. Okay, thanks so much. It just recurred to me. I'm not sure if you actually answered this or whether I lost it, but I think the question right before was about meditation and sleep and whether that's
Oh,
helpful.
yes. Yeah. So several studies showing that meditation can be helpful um, for sleep and for insomnia. Um, uh, it's not necessarily a particular area that I'm um, super fluent in beyond that, so I can't give any specifics about you know, duration,
Hmm.
frequency type of meditation, but certainly uh, lots of lots of data suggesting that it's helpful.
Yeah, yeah, absolutely. Um, Let me see here. What is an example of an activating antidepressant?
Oh, okay. Yep. Um, when I say activating antidepressant, I mean an antidepressant that is stimulating or wake promoting. So sort of the three antidepressants that come to my mind that are quite stimulating or activating, um, venlafaxine. The other name for that is Effexor. The other common one, Wellbutrin. Prozac is a third. I would say probably these three are um, at least in my mind, the ones that I think probably are the most activating or stimulating.
Okay, that's great. Thank you. For the level three home sleep study, someone's asking who reads or interprets the results? Should they be qualified to diagnose or speak to the cause?
Yeah. So a level three sleep study, often called a home sleep study, also referred to as a home sleep apnea test, or HSAT. Um, all of these tests, um, I mean, it's one study. There's different devices that do it, but they all kind of mean the same thing. Um, this is a test that's not used in Ontario very much, because it is not funded by our public system. So OHIP um, uh, is not um, a way to have this test sort of funded. And so because it costs money, um, most people will gravitate towards a level one sleep study, which is covered by OHIP and, you know, arguably more accurate and more comprehensive. But a home sleep apnea test probably does have a role when sleep apnea is suspected in individuals who might not be able to go to a sleep lab, maybe because of anxiety or mobility issues, etc. And these studies should be um, interpreted by a sleep physician. And so, the interpretation of a level one sleep study is something that every physician during their sleep medicine fellowship learn to do. And so, um, these sleep tests, these level three sleep studies should be interpreted by a qualified sleep physician. In other provinces, for example, Alberta, the College of Physicians and Surgeons of Alberta ensure that these tests are being interpreted by qualified physicians. Um, but I can't speak to, what's happening in every province and every city. But yes, it should be a sleep physician interpreting that study.
Mm-hmm. Great. Okay, thank you. Is there anything that can be done to address bruxism other than using a mouth guard?
Yep. So a mouth guard. Okay. So firstly, um, would be eliminating anything that could be contributing or driving it. So seems to be more common in people with sleep apnea, and probably treating sleep apnea lessens bruxism. More common in people with anxiety. So again, addressing the anxiety in the absence of sort of identifying any contributing factors that can be addressed. Um, a mouth guard is first line. It certainly protects the teeth, but also, in addition to protecting the teeth, probably does lessen the bruxism by way of some kind of biofeedback. We used to use oral medications for bruxism. The problem is that the oral medications that we used to use are fraught with side effects. And so generally a sort of a poorly tolerated approach. What's done probably more commonly is the use of Botox or botulinum toxin, which people on the call may be familiar with both for the use of migraine or for cosmetic purposes. But Botox, um, um, when injected into sort of the masseter and other muscles that we use for biting and chewing, can lessen bruxism. So if a mouth guard fails or if there's ongoing pain or injury despite the use of a mouth guard, then the administration of Botox into the masseters would be probably the next most appropriate treatment.
Okay, that's great. I'm going to combine two questions here. There's Adam's asking, I thought benzos or benzodiazepines in brain injury were not a good idea, and is asking about the risk versus benefit. And then someone else has just said clonazepam, good or bad?
Yeah, so okay, as purely a sleep physician, um, the only time I prescribe a benzodiazepine, specifically most commonly clonazepam, is for the treatment of REM sleep behavior disorder. So that is that neurological condition where we act our dreams. So we're dreaming we're, I don't know, being attacked and we punch in our sleep, or we're, dreaming that we're riding a bike and we kick our legs. So that is when I prescribe clonazepam. I never prescribe clonazepam or any benzodiazepine as a sleep aid or a hypnotic or like a sleeping pill. And you're right, I would be cautious about using that. It's because of risk of dependency, because of side effects. So that's the only time I use clonazepam is for the treatment of REM sleep behavior disorder. There
Okay.
are some contexts in which we use it as neurologists, but again, not certainly not for concussion.
Okay, great. How long before sleep should you turn off your devices?
Yeah, I don't think we know. I don't think we know the optimal time. Um, when we look at sort of the treatment of circadian rhythm sleep-wake disorders, you know, and when we're trying to um, uh, kind of recalibrate the system, we use bright light in the morning, for example, but um, so um, I guess just to say like we know the earlier the better. But I don't have like a specific answer as to what time one should shut it off. Um,
Mhm.
we start to upregulate our production of melatonin about 2 hours before bedtime. So perhaps there's a rationale to cut that off at 2 hours because we know light can influence our melatonin production. So if we're using, um, some physiology as a estimation as to when, then perhaps 2 hours before bedtime. That just seems a little bit overly aggressive. I don't know if that's even
Mhm.
possible in this day and age. And so, um, I guess what I would say at the very least, we shouldn't be using those electronics in bed. And I guess that's for two reasons. One is it implies that it's very close to bedtime, but the other is that you may be weakening the association between bed and sleep. So
Mhm.
electronics, as sort of a bare minimum, maybe no electronics in bed.
Right. Okay, that's great. Thank you. We are pretty much at time, but we let me just, if you don't mind, I'll get one more question in here. There were a number of questions around CBTI training, like where you can get it, or if there are any recommended apps that can be used.
Yeah, so CBT high um, is um, typically uh, delivered by healthcare providers who have done adequate training. I mean, if you are suffering from insomnia, you wouldn't do the necessarily the you wouldn't do the training for CBTI. You would just receive that as a treatment by what is typically a registered psychotherapist or a psychologist or neuropsychologist who's familiar trained with CBTI. And there's different organizations um, that provide even online certification for that. But if you're a patient or an individual um, then you would just seek a clinician, a healthcare provider, um, to kind of walk you through that. You would need to do training for it unless you want to be a provider um, of CBTI. There are some apps for sure. I mean, you can literally, I think you can like literally Google, CBTI
Hmm.
free app, and there's things I just can't speak to like I can't I don't know I haven't tried them. I haven't or at least not all of them. And so I can't like necessarily endorse one over the other, but there are self-led programs and apps that are available if cost is an issue.
Hmm. Yeah, it was just I'm the same. I haven't used any, but I know like the VA in the US has this one called CBTI Coach, which is free. I know there's a number of other ones, but yeah, I can't sort of speak to the quality of them, but they're definitely out there. So it would be as easy as I think doing a search. So Dr. Parekh, thank you so much for your presentation. I'm sorry to everyone, but there were so many questions. There were a number that we unfortunately couldn't get to. Um, but what I will say is that, as always, there'll be a short questionnaire coming your way, which just is to, we're always looking for your feedback and any suggestions and so forth. But if you have any specific questions that you didn't get answered, feel free to include those in your response. Just make sure that you also include an email address because they are anonymous. So unless you include that, we don't actually know where the question is coming from. And also, just so you know, this presentation, all of our presentations are recorded and they usually go up on the website, on the Canadian Concussion Center website, about a week after. And along with that, there was someone asking about the slides. So Dr. Parekh's slides will be posted along with the video, so you will have access to all of that and all of our previous presentations as well. So feel free to take a look. Just to let you know, we will be back in the new year. Stay tuned for there'll be a new flyer coming around with a new set of talks. We'll be getting started in January, but the details will follow. So again, thanks so much, Dr. Parekh, and yeah, I hope everyone has a great evening and a great holiday, and we will see you in the new year.